Well, hello, everyone, and thank you for joining us today for the State of Midwifery in California, which is a webinar series presented by Midwifery Access California. My name is Holly Smith, and I am a nurse midwife, and I have been a nurse midwife for 24 years. I am also the health policy chair for the California Nurse Midwives Association, and I also wear many policy and quality improvement hats in California. And one of those hats is as the co-lead for this coalition, Midwifery Access California, otherwise known as MACA, along with my partner in crime and right hand, Liz Donnelly, who is also a nurse midwife and practices clinical midwifery in the Bay Area. So the objectives for today are really simple, actually. This is meant to be an intro webinar. We will dive deeper in later webinars in this series that really get into the weeds on specific topics that I will be speaking about more generally today. But today we intend to learn about what is Midwifery Access California and how did we come to be, about the midwifery landscape in California as well, and then how midwifery stands to be a strategy for the triple problem, or what we're calling the triple threat of poor outcomes, poor access, and racism-based disparities. And I should say that funding for this series is provided by the California Nurse Midwives Foundation. So we just want to give a big shout out and thank you to the California Nurse Midwives Foundation. They are also part of this coalition. The mission of CNMF is to enhance maternal health in California and address disparities in outcomes by advocating for universal access to the midwifery model of care driven by a diverse midwifery workforce. It was founded shortly after SB 1237, which was the bill that created independent practice for nurse midwives in California. It was created shortly after that time and has expanded to encompass reproductive healthcare and abortion care and reflects a commitment to holistic healthcare. This organization does direct to student funding for midwifery scholarships. And in fact, they have donated up to more than $86,000 in total student grants so far. This is also the organization that has created the Rebecca Kaplan Memorial BIPOC Scholarship Fund in memory of a wonderful midwifery leader in San Francisco, Rebecca Kaplan, which is used to assist BIPOC students on their midwifery journeys and with an annual fundraiser. They also provide community project support. They have supported many community birth projects in California, including Kindred Space LA, Beloved Birth, Black Centering Project, and more. They have directly funded midwifery preceptors in order to support their work to do the clinical training of midwives in California. And they have also funded other projects, including anti-racism initiatives, community reproductive health and birth initiatives, and support for doing the boots on the ground work of midwifery integration, like the work of Midwifery Access California and this series. So we just want to say thank you again for the California Nurse Midwives Foundation for supporting this. All right, so Midwifery Access California is a large multi-stakeholder coalition. This slide is actually from 2023, and so we have grown since then, now that we're halfway into 2024, but at that time we had 33 total partners, which included more than 15 midwifery practices across the state, including home birth practices, birth center practices that were a combo of home and birth center or birth center and hospital, and some hospital-only practices as well. We also enjoyed the support and technical assistance from a few state agencies, including the LA Department of Public Health Perinatal Equity Initiative and California Department of Healthcare Services. There are now 3 Medi-Cal health plans that have joined our initiative to help us understand how we can improve midwife-led care with the help of Medi-Cal health plans and increasing reimbursement, improving contracting with midwives, and so forth. And those folks are LA Care, Blue Shield Promise, and Partnership Health Plans. So we're really grateful for the health plans coming on board and helping us to promote midwifery integration in California. And then we also have various community advocacy organizations who have partnered with us. And those organizations include the National Health Law Program, California Nurse Midwives Foundation, the California Nurse Midwives Association, the California Association of Licensed Midwives, the Black Maternal Health Center of Excellence at Charles Drew University, the California Coalition for Black Birth Justice and Pregnancy Pathways, as well as Maternal and Child Health Access. So if you go to our website, you will see that we already have 3 more webinars planned, and there will actually be more than 3 webinars. And we will be co-creating these with some of the organizations listed here in order to put out content for you that digs deeper and more specifically into some of the topics that I'll be discussing today. So be sure to tune in for more webinars that dig a bit deeper into specifics later. So about Midwifery Access California and what we do, our collective goal is to integrate midwife-led care into existing clinical practice settings, like clinics and hospitals, and to amplify and expand community midwifery, meaning midwifery care or birth care in homes and freestanding birth centers. What we believe is that midwifery care is a key strategy for improving reproductive health care access and outcomes in California. And our vision and the projects of our coalition are specifically focused on communities existing on the margins, those most impacted by social, economic, geographic, and health inequities and racism-based disparities. In terms of our history, MACA was born from the Midwifery Learning Collaborative, which was a project of the Institute for Medicaid Innovation, which was funded by the W.K. Kellogg Foundation. And if you go to that QR code in the top right, you'll get to read about this history and the 3-year collaborative that started in 2021 with the help of IMI. And now, since that collaborative is ending, the members of this group envisioned a continued collaboration of diverse healthcare and community-based experts to carry on the work of midwifery integration in California. We have a couple of projects that we have completed on our website. Go to midwiferyaccesscalifornia.org. You will find those projects, and they focus on reimbursement and the California midwifery payment model for community birth. And by the way, future webinars will explore those projects as well. Okay, so let's start by telling the story behind the story. Midwifery Access California came about for a reason, and you've just learned about the 3-year collaborative that led to this coalition. But hopefully the next few slides will also help tell the story behind why the initial people and organizations involved in this initiative have such a strong commitment to expanding midwifery as a strategy for improving maternity care. So the problem in the US and California is multi-layered. We have poorer maternity outcomes than other high-income countries. We have racism-based disparities that persist despite efforts to improve outcomes. And we have a lack of access to reproductive health and maternity care. And this access problem is actually worsening. So let's start with poor outcomes. Here are some key points I want everyone to understand. The United States is a clear outlier among high-income countries with a maternal mortality rate that exceeds even the other worst performers. And maternal mortality is just the tip of the iceberg. For example, rates of maternal and infant morbidity, meaning severe illness or near misses, are also high. And together they paint a clear indicator of a country's priorities and investments. For international comparisons, the World Health Organization, tracks maternal mortality. Where on the other hand, California and the US, we track maternal mortality as well, but we also track another quality measure called pregnancy-related mortality. And this can cause some confusion when analyzing the data. So I just want to put that out there a little bit. And the reason for that is because there are actually, in this moment, maternal mortality deniers out there. And this is strongly picking up pace. For example, there's an article in The Atlantic just a few days ago on May 30th that talked about this. And that's because recent analyses have shown that pregnancy-related mortality and maternal mortality may be a bit inflated in recent years based on changes in how data was reported. But I will also say that even those studies show that the US is still worse off than other high-income countries. And what's left out of these analyses often is that we still have very disparate outcomes between white birthing people and Black and Indigenous people, even in these best case scenario articles. So this graphic is from the Commonwealth Fund, and it shows our outcomes in graphic form. You can see the US overall there in kind of the darker green bar, which is the second from the right. And then compare that to Black birthing people on the far right and white birthing people, which is like the fourth one in from the right. Clearly a disparity exists between outcomes. So on to the second point of this problem, racism-based disparities in birth outcomes. This is from a recent article, what was last year, February of 2023, from the New York Times, which reviews the paper by the National Bureau of Economic Research on maternal and infant health inequality. And what they found was that even the richest Black mothers and their babies are twice as likely to die as the richest white mothers and their babies. So what that means is education or level of being affluent does not protect against this disparity in outcomes. And I should also note that whiteness is not protective for birthing people in California and the US either. Maternal mortality for white women in the US is also higher than other high-income countries. And I just want to give a big shout out to the California Maternal Quality Care Collaborative, who has made great strides in the state and has helped providers and hospitals alike to reduce pregnancy-related mortality. But still, racism-based disparities persist. And when you disaggregate the data to show the impact of racism-based disparities, Black women are dying at 3 times the rate of white women in California. In a study using more advanced surveillance techniques by CMQCC and the California Department of Public Health in 2021 showed that this rate in California is probably more like Black people, birthing people are dying at a rate of 5 to 6 times higher than white birthing people. This is from the California Healthcare Foundation. They have a great resource called the Maternity Almanac. And this just shows in an astonishing form the difference between the maternal mortality rates between Black birthing people, which is in blue up top, and white birthing people, which is in that kind of lime yellow color down at the bottom. And finally, let's talk about the third point in this 3-pronged problem, lack of access. Maternity units are closing at a rapid pace across America and California. In fact, 46 maternity units have closed in California since 2012. And lack of access is multifactorial. There's lack of providers, maldistribution of providers, closing of maternity units in hospitals, lack of prenatal care in certain locations, and then also that prenatal care providers often are driven away when maternity units close. Also, from an economic standpoint, when hospitals are big parts of an economy in a small town, when these hospitals close, that in turn further affects health due to the economics of closing a big industry. So it's not just that simply that site of care is gone, but the economy of that city is affected, which leads to poorer health outcomes. And I'd also like to say in the fourth point is that the access maps don't tell the whole story about maternity care access in California. It's really hard to find one map that truly tells the whole story really well. And here's an example. So this is a map of maternity deserts and maternity care access by the March of Dimes. I'm a big fan of the March of Dimes work and what they have done around mapping out maternity deserts. And the story it tells is not great for parts of California, and I'm really glad that policymakers are using these maps to improve access. But the story is more multi-layered and complicated than even this says. So if you look to the far left of the map, the one that's in the rectangle there, it's divided very simply into maternity deserts in red, low access to maternity care in kind of the brighter orange, moderate access to maternity care in the lighter orange, and then purple means full access. So specifically, a maternity care desert then is defined as any county without a hospital or birth center offering obstetric care and without any obstetric providers. So this makes sense, right? If you have nothing of something, then you are in a desert. So if you have no obstetric providers, no hospitals, that's clearly a maternity desert. Then they outline what is low access to care, what is moderate access to care, and then the definition of full access to maternity care is defined as the availability of 2 or more hospitals or birth centers providing obstetric care in a given county, or the availability of at least 60 providers offering obstetric care. But this might not be adequate to describe access in California, right? Think about just the sheer size of some counties. Look down at San Bernardino County, for example, which is a very large county, both has very rural areas and very metropolitan areas. Or think about the population of Los Angeles County in and of itself, which is over 9 million people, LA proper with over 3 million people. So it can't be that full access to maternity care is when you have a couple of hospitals and at least 60 providers. So you really have to drill down and dig deeper and go by even zip code or census tract or multiple layers of information to understand just how widespread this lack of access situation is. So I'm now going to put up a map that shows, this is from the Department of Healthcare Access and Information, HCI, and it shows health professional shortage areas for primary care. By the way, HCI has some wonderful data and maps that you can easily get from their website, and it makes sense. They are the Department for Healthcare Information, but also just want to give a shout out for HCI for consistently providing the public with really good information. So here we're looking at health professional shortage areas for primary care. There are various types of health provider shortage areas. Again, that gets back to the multifactorial nature of trying to describe lack of access. The easiest way to explain it is that there are populations, facilities, and geographic regions with an insufficient number of healthcare providers. And we focus on primary care providers, but you can also look at this in terms of dental providers and mental health providers and so on. So if you look at this map, the dark blue are geographic regions with an insufficient number of primary care providers. And the medium blue are high needs geographic regions with an insufficient number of, or I should say high needs areas with the same thing, an insufficient number of primary care providers. And then the light blue are places with populations that don't have sufficient providers to treat according to their needs. So populations like unhoused populations or those with substance use disorder. And so you can see at this map, there are counties that within the county have different kinds of shortages. San Bernardino, again, down here has all of the different kinds of shortages. If you look up here in Mendocino County, or is that Humboldt? Well, Humboldt or Mendocino, way up there in the north, sorry, northern folks, has both population shortage areas and geographic shortage areas. So the majority of the state has some kind of shortage area, right? And then looking at this is the Rural Health Information Hub, another great place to go to for great information. And they really make it very simple. They show it by light blue, which means none of the county is a shortage area. Gray means part of the county is a shortage area. And then that dark blue is all of the county is a shortage area. And what I see from this is that the majority of California has at least part of the county is a primary care shortage area. And this is from April 2024. Here in California. And then this map, I just wanted to be sure to show this one right now. This is showing mental health providers by county and the shortage of mental health providers. This is a huge concern lately because we know more now about how maternal mental health contributes to maternal morbidity and mortality and infant morbidity and how it can harm entire families. And often OB-GYNs and midwives and primary care providers, family practice are typically the first providers to assess for and find resources for birthing people or pregnant people with some sort of maternal mental health condition. But where are the resources? You can see here that over half the state, the entire county is a shortage area for mental health providers. And then the other half of the state, at least parts of the county, are a shortage for mental health providers. This is why everyone is so concerned about the maternal mental health component. This is an article called Chop Wood, Start Fire, Have Baby. It is from Alta Online, published a few months ago. It is a Truly a beautifully written article. I included it here because I think patient stories also tell the full depth of the access crisis that you might not get from a map. So I'm going to read a little bit here. When I go into labor, Ben and I will travel that same remote highway, Highway 20, most often referred to simply as 20, all the way to Ukiah. If the weather is good and there's no traffic or road work, the drive will take about 2 hours. We will not have cell service or any other way to communicate any emergency aside from a dozen or so bright yellow call boxes stationed roadside every 2 or 3 miles. Ben and I knew that in Fort Bragg, medical care would be more limited, but once I started to dig into prenatal and delivery options, I was surprised at the lack. How could a town that boasted nearly 7,000 people have not have an obstetrician or a labor and delivery department? We had an ER and some basic services like geriatric care, hospice, and some surgery, but what happened to the maternity care? And so keep in mind, this is Mendocino County. This is the same county that was showed on one of the maps as having full access to care. So what did happen to all the maternity hospitals? There was a recent Cal Matters investigation, great reporting done in November of last year by Kristen Huang and colleagues at Cal Matters that said at least 46 California hospitals have shut down or indefinitely suspended labor and delivery since 2012. That is a huge amount. And hot off the press, this article is from 4 days ago on June 6th of this year, showing the closures of LA area hospitals and the fight to keep one hospital open, Martin Luther King Community Hospital. And Martin Luther King Community Hospital happens to be a midwife-led hospitalist approach to birth care. Midwives do about 70% of the births at this facility. And it also happens that they have one of the very lowest cesarean section rates in the state, again, showing the benefit of midwife hospitalists. This is directly from that article showing the 17 hospitals that have closed in Los Angeles County since 2013 and divvied up by for-profit and nonprofit. Nonprofits are struggling to stay open. For-profits, which were the majority, tend to close when maternity care isn't making enough money, I think is what we can glean from that information. And then finally, the last lack of access data point that I want to give. The California Nurse Midwives Association did our own investigation a couple years ago on the hospitals in Northern California that offer vaginal birth after cesarean. And what I mean by that is those hospitals that calhospitalcompare.org shows that they, quote, routinely offer VBAC. Now, it doesn't mean that other hospitals won't let a patient have a VBAC there, but they will likely counsel a patient that they don't do VBACs because they don't have the supports in place in case an emergency were to arise. We went ahead and called every single one of those hospitals to confirm that reporting by Cal Hospital Compare, and we found that only there are two hospitals in these two counties that routinely offer VBAC for patients. So where do folks go when they have had a cesarean and they live in that area and they want to have a vaginal birth next? What are their options? So I hope I've given you a good overview of just how complicated and deep the access crisis is. It's top of mind for policymakers right now, and as it should be for the rest of us as well. Okay, so now you know about this many-layered problem of poor access and poor outcomes and disparities, racism-based disparities. This is what in public health we call a wicked problem. A wicked problem is a social, cultural, or institutional problem that's really difficult to solve. And it's difficult for a number of reasons. It can be difficult because there are multiple strategies involved by stakeholders that may have disparate goals or where there's competition amongst stakeholders. There can be changing standards and requirements, or frankly, just the complex interdependencies that I just described, for example, that can give rise to these wicked problems. But one thing we know for sure is that these kinds of problems must rely on multiple strategies, multiple solutions deployed together within a sustained effort and with appropriate funding. And so it's time, folks, to deploy all the solutions. We are in a maternity crisis. the plane is literally crashing, so to speak, and it's time to pull the ripcord and deploy as many parachutes as possible. And that's why we're talking about midwifery care today. So what is a midwife? Um, I know some of you know for sure what a midwife is, and you can just kind of zone out right now. But for those of you who are new to this conversation, midwives in California are clinical healthcare providers who care for pregnant people and newborns during pregnancy, labor, birth, and the postpartum period. This includes preventive care and the detection of abnormal conditions in the mother and newborn. It includes referral or consultation with physicians and other healthcare providers when indicated, and emergency care until the need has resolved or additional assistance can be obtained. Midwives can also prescribe and or administer medications, suture lacerations, and manage a number of complications independently within their scope of practice. And by the way, nurse midwives in California, and we'll talk about the differences in midwives in California, but nurse midwives in California can provide routine gynecologic care as well, including abortion in the first trimester, both medication and aspiration abortion independently in the first trimester. Midwifery is a healthcare profession that has been practiced around the globe for centuries, and I've pulled a few elements from the philosophy and model of midwifery care as it is defined by the International Confederation of Midwives, so that you can get a sense for the unique qualities of midwifery. But this is really just a small set. There are more elements to the philosophy of care and more elements to the model of care, but I think this gives a good idea of what midwifery means. So 2 elements from the midwifery philosophy of care. Midwifery care promotes, protects, and supports women's human, reproductive, and sexual health and rights and respects ethnic and cultural diversity. It is based on the ethical principle of justice, equity, and respect for human dignity. Midwifery care takes place in partnership with people recognizing the right to self-determination and is respectful, personalized, continuous, and non-authoritarian. We don't force anybody to do anything. There are 2 elements from the midwifery model care I want to point out. Midwives promote and advocate for non-intervention in normal childbirth unless it's really necessary. And midwives practice in collaboration and consultation with physicians and other healthcare professionals to serve the needs of the woman, her newborn, family, and community, meaning we try to give the right care at the right time and refer to a higher level of care when needed. So it's really important to know that collaboration is a key part of the midwifery model. So in a nutshell, midwifery philosophy has long preserved 3 immutable elements. First, partnership with the birthing person or patient-centeredness, the therapeutic use of the human presence, which I think is a beautiful way to describe what midwives do in terms of the relationship that's built with the client, and non-intervention unless necessary for the health and well-being of the pregnant person and or the fetus. So midwifery care is whole person care. It views pregnancy, childbirth, and postpartum as integral pieces of the life course rather than separate transactional healthcare events. And put simply, in the community midwifery model, meaning those midwives who practice more in birth centers and home settings, patient-centered care, comprehensive care management, and linkages to social services are all baked into that one model. Interestingly, the midwifery model of care is standard in all countries that have better birth outcomes. And you can see on the far left here, we have the US and Canada. And then as you move up to the right side, every single other country with better birth outcomes has a much larger proportion of midwives to physicians. And that's not to say that obstetricians, physicians aren't needed in maternity care. That is absolutely not the case. As I said previously, that team approach where we rely on collaboration and giving the client the right care at the right time is essential. But we are talking about here is complex systems change, which cannot be achieved by simply continuing the status quo. I believe it's imperative, and so does many of the folks in Midwifery Access California, that it's imperative that we look at the data with fresh eyes and ask ourselves, what are other countries doing that we haven't really tried yet? And I would say that midwife-led care for the general healthy population is one of those things we haven't tried or haven't really put the systems in place to be able to try it to any significant degree. Of note, the Netherlands, which is one of those countries noted here that also has a really great integration between the midwifery model and the medical model. Maternal mortality rates have dropped in recent years, and research has shown that there was an increase in home births and vaginal deliveries and a decrease in cesarean sections, both planned and emergency, during the pandemic. And the researchers were able to contribute those practices to the lowering of maternal deaths during that time. So as I was saying, the system works best when we all work together so that every patient gets the right care at the right time. So for those who want to learn more, this series will have actually an entire webinar on doulas and midwives and their differences and how we work together. But for today, I will give a really brief overview. As I said, midwives, we are professionals that are trained healthcare providers responsible for the health and well-being of the pregnant person and the newborn, and we are experts in supporting low intervention pregnancy care. Physicians, meaning obstetricians, maternal fetal medicine specialists, family practice physicians, are medical care providers who are trained in reproductive health care and also trained in surgery and more invasive procedures, and are clinical care providers for high-risk pregnancies. And then doulas are professional community support. Doulas provide emotional, physical, practical support. They connect pregnant people with resources, provide guidance and education, and offer non-pharmacologic pain management and encouragement and continuous support in labor. And in fact, ACOG says that doulas may be one of the most effective tools to improve labor and delivery outcomes. This is a Venn diagram, obviously. It is meant to be a Venn diagram. Because all of these three professionals overlap in some way, but nonetheless have very distinct roles and distinct training and scopes of practice. And it is our belief at Midwifery Access California that if those roles were used more efficiently to serve the patient, we would have improved outcomes at a lower cost. There's a huge bench of evidence now that shows the benefits of the midwifery model of care. In fact, it's hard to find that one study that proves these things because there are so many of them now. So these are just a few of the outcomes we see with the midwifery model of care when compared against the typical model of care in the United States. So it is more likely with the midwifery model that one will have a spontaneous vaginal birth, a trial of labor after cesarean, a vaginal birth after cesarean, higher breastfeeding rates, higher rates of patient confidence and control, higher patient-centered care as reported by the patient, and lower costs. And it is less likely to have a cesarean birth, an operative vaginal delivery, an induction of labor, episiotomies, perineal lacerations, use of pain medicine or epidural anesthesia, less likely to use or need continuous fetal monitoring, which leads to higher rates of cesarean in some cases, lower NICU admissions, lower preterm birth, and low birth weight infants, which is one of the highest costs in maternity care and leads to lifelong morbidity, fewer infant emergency department visits and hospitalizations, and fewer neonatal deaths. I do want to talk about a couple studies, though, that are critically important. This first study is by the Birthplace Lab. This study found that overall integration of midwives into the maternity care system is correlated with improved outcomes. This was really an amazing study that was quite nuanced. But what they did is they looked at all 50 states and they scored each state with a level of integration. And by integration, they meant things like ability to prescribe, ability to work without supervision, ease of communication between provider types, and ability to transfer to higher levels of care, and then compared those integration scores with the outcomes in those states. So I'm not going to do it justice because this was quite a rigorous analysis, but in short, what it showed was, in general, where midwives are less integrated, outcomes are poorer. So increased access to midwifery care in terms of integration, density, and the ability of patients to access that care results in increased breastfeeding rates, according to the study, reduced interventions, higher rates of VBAC, and lower rates of neonatal death. I am actually going to skip this slide for now due to time, but it will be in the slide deck, and it's like a 2-minute video on this study. Oh, maybe it's playing. Actually, we're gonna skip through that. All right. And now this is a study by CMS that compared 3 models of care distributed across the nation. So those 3 models are maternity care homes, group prenatal care, and birth centers, or care by midwives and birth centers. And I just want to give a quick review. That maternity care home definition, for those of you who are new to this concept, don't want to confuse anyone. It's not a place where we put people during their time for maternity care. It's a concept, not a place. It means that the patient has like a designated location and provider from whom they receive care. And also that person does extensive care coordination and refers to other enhanced services when needed. So they're the provider of clinical care and the entity that ensures continuity. So just in terms of defining what maternity care home means. So there was a total of approximately 45,000 participants over 4 years. So it's a very big study. The participant characteristics were 39.8% of them were Black, 29.7% were Hispanic, and 25.6% were white. The vast majority were within the typical childbearing age, but 15% were in their teens, meaning under age 20, and 9% were 35 years or older. And what they found was that Strong Start participants in birth centers and group prenatal care had better outcomes at lower cost relative to other Medicaid participants with similar characteristics. And so I want to zoom in on those outcomes there. Birth center participants had better outcomes relative to maternity care home participants, meaning they had lower rates of preterm birth, lower rates of low birth weight, lower rates of C-section, lower rates of, higher rates of VBAC. So I want to point out that this study really says a lot about the state of midwifery care in California and nationally. We know this now, that birth center care improves outcomes at a lower cost for Medicaid patients. And yet it feels like, seems like, looks like that maternity care transformation efforts continued to be focused on how to make our currently broken system do better at enhanced care coordination. Not that we shouldn't be focusing on enhanced care coordination, we absolutely should be, right? In primary care, we see the extensive benefit of the medical care home model, whether it be for substance use disorder, mental illness, and certainly for pregnancy, having enhanced care coordination is really key. But it seems like we are putting all of our eggs in that basket, which for Medicaid recipients happens to be the least effective and least cost saving of these 3 here. So rather, it seems like we should at least be putting some eggs in the basket of funding and building up midwifery care in all clinical locations and expanding community midwifery in homes and birth centers wherever possible. So again, the key takeaway here is that women who received prenatal care in Strong Start birth centers had better birth outcomes and lower costs relative to similar Medicaid beneficiaries not enrolled in Strong Start. So let's talk about midwifery and racism-based disparity. Racism-based disparities are a result of a multi-layered problem, once again, social, economic, environmental, and structural disparities, all rooted in racist origins that contribute to differences in health outcomes both within and between groups. Whether that be immigration policies, incarceration policies, hiring practices, who banks give loans to, redlining of neighborhoods, education admission practices, overt personal racism, or implicit bias. You can see how there are all these different levels of racism that collectively affect health. And because of that, communities of color are best poised to determine the strategies that will create effective change based upon their very personal experiences. To that end, advocates for disparity reduction in organizations grounded in reproductive justice are calling for access to midwifery care as a key part of improving outcomes for their communities. Black Mamas Matter policy agenda notes that they desire expanded midwifery licensure and access, increased access to birth centers, to develop home birth infrastructure. Amen to that one. We definitely need a home birth infrastructure. The California Black Birth Justice Agenda noted the need for expanded coverage for community-based care to increase access to holistic support. And additionally, Black birthing people want midwifery care. If you look at the right side of the screen, this is according to the California Healthcare Foundation Listening to Mothers in California survey. Overall, 54% of people reported an interest in having a midwife as their maternity care provider should they have a future pregnancy, but only 9% actually had a midwife. And when this is broken down by race and ethnicity, you can see the box there. The contrast between actual and desired care was greatest among Black birthing people, with 66% being open to the idea or wanting a midwife, in contrast to just 6% who actually had a midwife birth attendant. So Black community leadership consistently identifies access to midwifery care as a critical intervention for racism-based disparities. But it's not just that communities of color want more access to midwives. The data increasingly shows that this is a real strategy. And so this is the slide you saw previously from the Strong Start study. And here's a quote from that report. Strong Start birth centers demonstrated a mitigating effect on health disparities, narrowing the preterm birth gap for Black and Hispanic birthing people compared with the matched Medicaid comparison group in the Strong Start impact analysis. Furthermore, both Medicaid groups included more birthing people who were living at the intersections of poverty, including unmarried Black and Hispanic people, with fewer years of formal education than the comparison group of privately insured birth center consumers. The birth center model demonstrated equitable outcomes between private and public payers, suggesting a potential role for the wellness-based model in the mitigation of poverty-related health disparities. It's a really strong statement. But I would be remiss if I didn't note the need for culturally congruent care. Maternity care and reproductive health care are very personal experiences and therefore often rooted in our own very personal, historical, traditional, and cultural experiences. So the call for increasing midwives to reduce racism-based disparities is not just a call for midwives generally speaking, but also for us to do the deliberate work of creating access to Black and Brown and Indigenous midwives. Here's an excerpt from the Black Mamas Matter Alliance publication with a quote from Dr. Joya Creer-Perry, who's the founder of the National Birth Equity Collaborative. She says, ahistorical care is part of how we got to a place of mistreatment and inadequate care. In order to be accountable to Black women patients, providers must know and acknowledge the history of medical apartheid in America and the history of extensive non-consensual medical experimentation on Black people and Black women in particular. Black women have a long history of being subjected to reproductive violations, coercion, and non-consensual acts of medical violence. That history, more recent than many suspect, influences how Black people interact with healthcare systems and providers. So care that doesn't consider and understand these unique experiences can't really have the full effect of creating real equitable outcomes. So this means we need to be very deliberate in how we grow the workforce and how we integrate congruency into our workforce development efforts. Integration of midwives and increased access to community birth are strategies that directly confront the root causes of racism-based disparities and the complex systems that enable it. And here we have a collection of resources that you can go to explore this idea, including from Black Mamas Matter Alliance, Partnership for Women and Families, and Every Mother Counts, and more. And now on to midwives and increased access. Midwives tend to practice in communities with the most need. Compared with physicians, a greater proportion of certified nurse midwives practice in rural areas and health professional shortage areas. Midwives also are more likely to care for women who are insured by Medicaid or from underserved populations. And in 2019, the California Healthcare Foundation survey found that 72.6% of CNMs answered always or almost always, or to a considerable degree when asked the extent to which they worked with underserved populations. And about 1/3 responded that between 76% and 99% of their patients were Medicaid beneficiaries. And then this last thing here, the single best predictor of the distribution of nurse midwives in a state is the degree to which midwifery practice is restricted. So the reason I note that on this slide is because we often hear, well, if midwives are so awesome and can and should be doing more, why aren't they? Or you also might hear, there must be a reason, we're such a small percentage of the maternity care population. There must be a reason for that. How can we ever meet the need? But the truth is, and I'm going to talk a little bit more about this as we get into California stuff, is that midwifery in California and the US has a very complicated history, and that has led to very restrictive practice environments, meaning laws and regulations that deplete midwifery and the ability to practice it rather than uplifting it and expanding the profession. So I want people on this call to hear that if midwives could meet the need if we had the political will and the motivation to break down those regulatory and statutory barriers that prevent practicing to our full level of training and education, and that prevent access by people who need midwifery care the most. And of course, the White House is catching on to this. We saw this in their White House blueprint for addressing the maternal health crisis. As it has also gotten the attention of Congress, the Government Accountability Office has written a report on births and workforce and midwifery education. This was last year. All right, let's talk about midwifery in California. Many of these pictures, by the way, in this slide deck are from midwifery partners in Midwifery Access California. And this just happens to be Kimberly Durden from Kindred Space LA. So the US, again, as I said before, has a rich and pervasive history of midwifery since this country was established, but there has also been a strategic effort to eradicate midwives in the US and frankly in California, especially Black midwives from the US maternity care landscape. So this series will also include a more detailed account of the history of midwifery in a later webinar presentation, and it is truly fascinating, the history of midwifery. So tune into that webinar if you are interested. But for example, the Madera County Project, which is just one example of many. The Madera County Project started in 1958, and that's when the California Department of Public Health recruited nurse midwives, which were at that point called nurse obstetrical assistants, to come to Madera County in the hopes of staffing the Madera County Hospital, which has recently closed in the last couple of years, and in the hopes of improving neonatal and maternal outcomes. It was a 3-year project from 1960 to 1963. Neonatal outcomes were improved significantly. Neonatal death decreased significantly. There was improvements in prenatal care and nutrition and increased prenatal visits. However, nurse midwives were nonetheless not allowed to be licensed in California until 1974 because the California Medical Association opposed the licensure of nurse midwives after the project, despite the significantly improved outcomes in Madera County. And I only bring that up specifically because it is located and noted in that Green Journal reference there. The Green Journal is the American Journal of Obstetrics and Gynecology, and they note there that that was the reason why nurse midwives were prevented from moving towards licensure. So it wasn't until 1974. But you can learn more about that history in another webinar. Okay, so here's where it starts to get as clear as mud, okay? In the US, there are certified nurse midwives, and certified professional midwives. And in California, we refer to midwives as certified nurse midwives and licensed midwives, which for ease of translation means certified professional midwives in California. This slide shows the differences and comparisons between us. So licensed midwives are licensed by the Medical Board of California. Many carry the National CPM certification. Their certification body is the North American Registry of Midwives. Their professional association is one of the organizations involved in Midwifery Access California, and that's the California Association of Licensed Midwives. And the majority of licensed midwives in California provide care in homes or freestanding birth centers. Nurse midwives, on the other hand, are licensed by the California Board of Registered Nursing. Our certification body is the American Midwifery Certification Board. Our professional association here in California is the California Nurse Midwife Association, and the majority of CNMs provide care in hospitals and outpatient clinics associated with hospitals, but there are some that provide care in homes and freestanding birth centers. This is just a quick shout out to the CMQCC toolkit that if you go to this QR code and then go to table 40, you'll see some really good resources where you can dig into this more if you really want to understand the differences between these different licensure and certification types. So just to present this then in graphic form, you can see that there are CNMs in the hospital facilities, licensed midwives and CNMs in freestanding birth centers, and then licensed midwives and CNMs in the home. There are many more licensed midwives practicing in the home setting than CNMs. They are really the specialists in community-based care. Here is a little description of the training requirements for California midwives. So CNMs complete a nurse midwifery education program approved by the Board of Registered Nursing, and then they go on to take the American Midwifery Certification Board exam, or the AMCB exam, for the CNM certification. Licensed midwives in California are required to take a 3-year licensed midwifery education program approved by the Medical Board of California, and then they sit for the North American Registry of Midwives Board exam, or the NARM exam, to complete the CPM certification. And in both cases, though, CNMs and LMs may also have an equivalent or challenge test way of getting the LM license or the CNM license in California without having to go through these methods here. For example, foreign trained midwives can prove their equivalency in their training. This slide is from the Government Accountability Office showing how many midwives there are in the US right now, and midwifery students. So students are in red and midwives are in yellow and blue there. So let's talk about the LM and CNM education programs. Right now, there are no licensed midwife education programs in California currently. In fact, there was one licensed midwife education program that recently closed a couple of years ago in Southern California, sadly. And now there are only 2 certified nurse midwife education programs in California, and those programs are UCSF and Cal State Fullerton. The University of California, San Francisco, or UCSF, is actually one of the top nurse midwifery programs in the United States, and it started in the 1970s, right after nurse midwives gained the ability to be licensed in California. They have a very diverse faculty, very diverse applicant pool and students. UCSF is the pipeline for new nurse midwives in the Bay Area and Northern California. However, there has been a recent decision by the School of Nursing to no longer offer a master's degree pathway for nurse midwives. So what this means is they will only offer a doctorate in nursing practice as the degree pathway for nurse midwives. This adds a full year of non-clinical didactic education and doubles the tuition. And what's important about that is that new graduates will have higher debt without increased clinical learning. And studies show that higher debt prevents students from seeking jobs in medically underserved areas. So this decision has caused UCSF to pause their program as they reorganize. And this reorganization and pausing is happening during a maternity access crisis. And that means the graduating nurse midwifery workforce will be cut in half over the next few years while the program is paused. And it also means that the Midwifery Workforce Training Act, which was a bill that was enacted a couple years ago to fund midwifery education programs, will now be dollars wasted as this school reorganizes and pauses their program. There should absolutely be a master's pathway for nurse midwives at UCSF. I bring this up because to understand the state of midwifery in California over the next few years, this decision is one that is key to the workforce issues we face now and in the future, and it will likely be broad-reaching with possibly negative effects. And it shows that even now in 2024, universities that educate midwives don't quite understand that midwives aren't nurses, that our role is distinct from nursing. And that means decisions like this that can be detrimental to midwifery while simultaneously being positive for other nursing specialties. So in particular, this notion that higher debt prevents students from seeking jobs in medically underserved areas should be a sign that we shouldn't be making midwifery education more expensive. And this is important because let's look at midwives by the numbers. If you're asking, can we meet the need right now? Well, right now, the answer is no. By these numbers, you can see that we must invest in the midwifery workforce. And the story I just told about UCSF should make more sense now. First, I should say also these are from different data sets, and I'm not trying to confuse people, but if you pull data from different years, different data sets, we're going to have slightly different numbers. And frankly, this is a problem for midwives in California. We don't have a great and efficient one-stop shop for midwifery data, whether that be about midwifery licensure and midwifery outcomes and so forth. So apologies for some of these numbers not adding up perfectly. But there's approximately 1,100 midwives total in California. And you can see the breakdown between CNMs and LMs. In Medi-Cal, as Medi-Cal providers, there's about 900 midwives total. And very few of those are licensed midwives, however. And there's 39 total freestanding birth centers as of 2023, but 16 birth centers have closed since 2021. Birth centers face the same issues that maternity wards face in that reimbursement does not meet their basic costs. There are 7 licensed birth centers and 11 accredited, and we'll talk more about that in a different webinar about birth center licensure. And these next few slides, I know I'm getting low on time here, but I just want to make sure that we get to everything. These next few slides show similar things in that midwives attend about 11 to 12% of the births in California. This slide here, if you were to look at that more closely, shows that the majority of births for CNMs are in the hospital, about almost 50,000 births a year by CNMs in the hospital, and then many fewer in homes and birth centers, while LMs have the majority of their births in the home setting and some in birth center settings. If we look at all births, so not just midwife births, but all births in California, you can see that 2% occur outside of the hospital. So while this might seem small right now, don't be fooled. In fact, community birth in California is increasing, thankfully. And the reason this is so important is because community birth is where the midwifery model of care, the model I described previously that is patient-centered, whole person care with longer visits and that relationship-based model, this occurs more in the community setting. And it's not that this doesn't happen by midwives in the hospital setting, but the dominant model of care often prevents the ability to form that relationship with patients and have the longer visits and have the same provider for birth and so forth. That's, unfortunately, the design of the dominant model. It's a feature, not a bug. And this shows just how much community birth in California is increasing. You can see that this is also from the CHCF Maternity Almanac. And on the right side there, you can see that the number of licensed midwives in the last 10 years, or between 2007 and 2017, increased 133%, and out-of-hospital births increased in that 10-year period by 130%. And we are seeing a similar thing nationally, and we're seeing it more for communities of color. For non-Hispanic Black women, home births increased 21%. In 2021 from 2020, and the percentage of home births increased 36% from 2019 to 2020. So just a year by year increase. So I want to talk about the scope of practice in California, and I promise you I will be done in a couple of minutes. But first we need to look at the practice environments for midwives nationally. CNMs gained the legal right to practice in California in 1974, and we gained the independent practice, meaning no physician supervision, in 2020. So it took about 50 years to get to that point. And thank you to Senator Dodd, who helped us with that. And then in 2023, came right back at it and fixed a few more things like the ability of CNMs to finally provide GYN care across the lifespan. But if you look at this map nationally, you'll see that California does not say independent practice per this map. And that's because there are still some restrictions on our practice in place. For licensed midwives gained the legal right to practice in California in 1993, and then they gained independent practice in 2013. What this map also shows, though, is that there are 12 states and 3 territories where CPMs are not authorized to practice at all, and where they are at risk then of criminal prosecution for practicing. This, of course, drives the practice of midwifery underground and creates barriers to access for people who need it most. That's a little bit about the national landscape. The scope of practice in California for nurse midwives and licensed midwives are similar with a few differences. So for nurse midwives, our scope includes low-risk pregnancy and childbirth, prenatal, interpartum, postpartum care, interconception care, family planning, STI care, immediate care for the newborn, and low-risk gynecologic care, medical abortion, and aspiration abortion in the first trimester. And low-risk pregnancy is very spelled out, and this is what makes us kind of one of those more restricted states instead of full independent practice, because the law has to spell things out so explicitly instead of trusting that midwives will practice according to their training and education. But we are here for low-risk pregnancy, single fetuses, head down, gestational age between 37 and 42 weeks, and the patient has no other pre-existing medical conditions that the midwife isn't trained to handle. Nurse midwives can attend the care of patients with moderate and higher risks issues, but have to do so in collaboration with a physician. Licensed midwives in California, their scope is normal pregnancy and childbirth, prenatal, interpartum, and postpartum care, including family planning care and care for the newborn. And normal pregnancy and childbirth is defined pretty similarly as it is for nurse midwives. And of course, this includes all the things that go along with giving care in a safe way in the community setting, like medications to control bleeding, the ability to suture the perineum, to cut an episiotomy if needed, those sorts of things. And sometimes folks don't realize that there is a scope of care for newborns, especially for community midwives, that encompasses all the things a newborn gets in the hospital setting, normal newborn. So whether that be newborn exams, vitamin K prophylaxis, vitals check, weight check, congenital heart defect screening, hearing screening, midwives in the community do all of that. And most babies who are born in the hospital after the mother has transferred, for example, will go back to their midwife for newborn care for that first month before they start to see a pediatric provider, and midwives refer to pediatric providers for any concerns. All right, we're close now, folks. So the term integration is something that's really difficult to measure. It's because we don't actually have an accepted definition of midwifery integration, but we do know that it is more than just utilizing midwives. In California right now, we have some good things happening. There's state funding for midwifery education. There's the growth of community midwives and BIPOC providers, advocacy for equal reimbursement and contracting, midwife-led care for Medi-Cal enrollees. We are working on amending those arbitrary laws that restrict access. There's a rise of midwifery advocacy by the organizations involved in the Midwifery Access California and other organizations. And California is a reproductive freedom state, which by definition embraces patient choice, right? So these are all good things. But we still have lots of issues, like hospital midwifery is elevated above community midwifery. We have disrespectful transfers of care for people who have to transfer from a home birth to a hospital setting. We don't have readily accessible midwifery outcomes data that is essential. Sometimes we utilize midwives in the hospital setting as physician extenders instead of as being able to actually practice midwifery. So there's a lot to work on here. And this results in a reduced size of the California provider network, reduced or eliminated patient choice. It decreases safety and quality of maternity care, which leads to poor outcomes, obviously. Increases in medical intervention, and this is a significant cost to the state and to consumers. And ultimately, the effects of this are carried mainly by BIPOC patients and those who are socially and economically disadvantaged and geographically isolated. But there's a lot of work to do. And that's where I'm going to leave you today, because this is the work that needs to be done. And this is precisely the work of Midwifery Access California. So in future webinars in this series, we're going to go more deeply into some of these topics, and you can find those topics at midwiferyaccessca.org/webinars. And also registering for this webinar means you'll get information about the future webinars. And if you are of like mind here in that you believe in this work and you have something to say, come join us. You can email my colleague, Liz Donnelly, at that Gmail address there, and she'll get back to you to set up an onboarding for Midwifery Access California. And if you are not of like mind, let's say you're from an organization that might, or personally may not be fully convinced yet of the power of midwifery care, I would just say don't stop the progress. Let's have some discussions on how we can work together for patients, because I bet we can agree that we want to improve outcomes and the access problem. And that's something we can agree on, then that's an opening. And let's work together to make that happen. So I just want to say thank you to everybody for being here, and this recording will be available to you soon. Thanks, everyone.